Alright, so here's the lecture on influenza viruses, or Orthomyxoviridae. That's the family of viruses. And I'm going to record this lecture in a couple segments so that the smaller file sizes are easier to download if you're in a situation where you don't have as much bandwidth as you perhaps used to. So to get started, influenza viruses we think have been around for a really long time. Perhaps as early as 400 BCE. And they have caused many epidemics and pandemics throughout history. And many virologists think that we're in for another really big pandemic that could kill millions of people, and I am one of these virologists. I've mentioned before in class, influenza is the thing that scares me the most. And we'll go through this lecture and we'll talk about why. So we've got seasonal epidemics every year. And why do these epidemics spread really quickly and become unmanageable? And there's a few really good reasons. All right, a very short incubation period. And then once you get sick, it spreads through respiratory droplets. And these droplets can contain up to 1 million particles per droplet. And the infectious dose of influenza is about 1,000 droplets. So it's very easy for influenza to spread this way. And then, of course, symptomatic people do not stay home. When people get the flu, people go, it's just the flu, and they continue to go to work. And this is for a variety of reasons. Some people are cavalier about it, but some people don't have health insurance, or some people can't afford to take time off work. For whatever reason, sick people don't stay home. There's no mandatory shelter in place, as they're considering in Bangor now. And then, because the virus mutates so quickly, there's a lack of herd immunity. So every year, it's a new influenza virus. And when people don't stay home, then it spreads in schools. And schools are actually one of the biggest incubators for influenza pandemics. And when people stop showing up at schools and work, that's when you know that you have a serious epidemic. So it's important to recognize the clinical features of influenza, and they are different from the common cold, right? So the common cold is not influenza. In influenza, you get an onset of symptoms pretty suddenly. So you might be feeling okay at 8 a.m. and then by 8 p.m. you're feeling kind of sick. You're feeling pretty sick. So relatively quick onset of symptoms after a short incubation period. Bad headache, muscle aches, particularly in the back, but all over. Fever. Pretty high fever. You do not get a fever in the common cold. All right, this is really important. You do not get a fever with the common cold. It's pretty rare. Malaise is just generally feeling bad. Dry cough, sore throat, and this is key. In an uncomplicated case of influenza, your chest x-ray will look normal. You usually get better after 7 days, so you can continue to have a lingering malaise for another week or so longer. Now, this is for an uncomplicated case of influenza, and one of the things that's very common, especially in people with immunocompromised conditions, is that the influenza infection is going to damage your lungs. It damages your lungs, it damages your airways. And this opens up the door for a secondary bacterial pathogen. And so it's very common, especially if you are in another risk group, is you get the flu, and the flu is bad enough. Like, you've got a high fever, you're on your butt with muscle aches and a headache, you don't want to get up, you're coughing, and then you get a bacterial infection. after the flu. And then in this case, you would have a cloudy x-ray. And you might go from a dry cough to a productive cough. So this is a big concern with influenza, and a lot of the flu deaths that we have every year are due to these secondary bacterial pathogens that you would not have otherwise gotten if you were healthy, that you would not have otherwise gotten if it weren't for the flu. Now, very rarely, there are some other conditions or other illnesses that can occur after influenza. So the first here is Reyes syndrome, and this is again very rare. It's usually in children, not always, but usually in children, and it's associated with aspirin use. This is why they tell you do not treat children's fevers with aspirin. Now, this causes damage to all of the organs of the body, but in particular, you get a lot of inflammation in the brain and excess fat buildup in the liver and liver damage. This can be very, very serious. There's no really good treatments for this. This can occur after other viral infections too, but it most commonly occurs after influenza. And it's there's some genetic predispositions. This is a metabolism problem, where there's a problem in fatty acid metabolism. Now, another rare event is Guillain-Barré syndrome. I never pronounced that exactly right, but those of you who are French-speaking can do a better job than me. Guillain-Barré syndrome is an autoimmune problem, and this can occur after influenza. It can also occur after the flu vaccine, very rarely. It can also occur after a bacterial infection with Campylobacter jejuni. And this is the most common situation, is after this bacterial infection. But occasionally it can occur after influenza, and it's when your immune system confuses a glycoprotein on your nerve cells with that of the pathogen, either influenza or Campylobacter jejuni. And then your immune system starts targeting your nerves, and this usually starts at your feet, and then it progresses up your body, and if it gets to your diaphragm, then it can cause problems breathing. This does resolve, though sometimes it can take like 6 months or a year or more for it to resolve. And the treatment is usually with immunoglobulins. So you use plasma therapy or antibodies to treat this. Again, these events, both of them, Reyes syndrome and Guillain-Barré syndrome, are both very rare. So how do we classify influenza viruses? Well, all influenza viruses are in the Orthomyxoviridae family. So ortho means like standard, and myxo is mucus. So this is like the standard viruses that cause influenza, I guess. There are 3 types of influenza viruses that infect people. We've got A, B, and C. All 3 can cause similar symptoms but of varying severity. And it's important to note that these are different enough that if you get infected with influenza A one season, it does not confer immunity against B and C. Now, every year we're really worried about pandemics of influenza A because it's zoonotic and it can infect all sorts of other animals. And so we're worried about the reassortment and the new viruses that are going to come out and spread across the world and kill lots of people. Influenza B only infects humans, so we still have a little bit of seasonal variation, but we're not concerned about the great big new pandemics with influenza B. Influenza B can cause severe illness, but it's usually in elderly patients. Influenza C causes more of a cold-like symptoms. It's much more mild. So we are primarily going to focus on influenza A and a little bit on influenza B. Now, how do you test for the flu? The most common ways that you test for the flu are with ELISAs. This is a point of care test. Or you'll see this abbreviated POC, point of care tests. They also have some PCRs tests, or you can look at it in cell culture. This takes much more time, but it's also more accurate. ELISAs rely on the specificity between the antibody and the antigen. These are very fast, but because they rely on that specificity, they can result in some false negatives. Occasionally you get a false positive, but the false negative is the bigger problem. So false positives are pretty rare. False negatives are fairly common because you've got your antibody and it's specific to the antigen on the virus. But if this virus has mutated, then the antigen has changed and it won't bind to the antibody anymore. So these are these tests are very cheap. They are very easy to do. They're very fast, but you get more false negative results than would be ideal. How does influenza cause disease? Well, influenza, we know, spreads by droplets. These droplets are breathed into the respiratory tract, and then they attach to the epithelial cells that line the upper respiratory tract. So the sinuses and the bronchial passageways, the trachea, but they stay primarily confined to the upper and middle respiratory tract. Now, when they enter these cells, they destroy them, and these cells are ciliated, and that cilia is really important for that mucociliary escalator that's constantly beating upward and moving mucus and dust and debris and bacteria and so forth up and out of the lungs. When these cells get destroyed, the cilia can no longer beat, so it gets harder to effectively cough up mucus. This also means that you're really opening yourself up for those secondary bacterial infections that can be very, very serious and potentially lethal. Now, it's important to note that normal seasonal influenza really does stay confined usually to the upper and middle respiratory tract. Now, more virulent cases of influenza, like the 1918 pandemic and the H5N1, those can infect the lower respiratory tract. So H5N1, for example, can infect the lower respiratory tract, and you can get much, much more sick. Now, there is, in your book, this virus file 9.2. This is a really, really good one for you guys to read and focus on. So it talks about some of the reasons we think the 1918 pandemic was more virulent and why H5N1 is more virulent, because it can infect more lung cells. It also stimulates your immune system more, and you get a cytokine storm. You get a lot more damage in the lungs. I want you guys to make sure you read on page 424 in your book, The Pathologist's Nightmare, and this describes one pathologist's account of a flu patient in 1918. Now, influenza is an interesting virus for a lot of reasons, but one in particular is that in patients, if you just isolate it directly from the patient, you get more of a helical form that is shown right here. But after you grow it in tissue culture, in a petri dish, you get more of this kind of round shape. So this is what you're going to see if you take it out of a patient. Now, when we're naming viruses, like you can see here, there's a format for doing it. It's a type of influenza. This would be A, B, or C. You're going to species that you isolated from. Now, this was isolated from a person, so it's not listed, but if it came from a pig or a bird, you put that here, the place of isolation. So we don't just call these Chinese viruses. They come from specific places like Wuhan or Hong Kong or Reston. For example, there is a Reston Ebola strain that we'll talk about later in the semester. Strain designation, the year it was isolated, and then we always list the hemagglutinin and the neuraminidase subtypes, and we'll talk about these subtypes further on in the lecture. So I'm gonna pause this one here. So this will be influenza lecture part 1, and I'll record the rest of this a little later this evening.